Bismillah ar-Rahman ar-Rahim. Thank you very much for directors and organizers of this course. So listening a very outclass presentation since morning. I am very impressed by the presenters. They are from us, but giving them opportunity has proven that they can present like an international speaker. So I am thankful to directors who have given me a chance and very happy to see shining faces from satellite centers and my young fellows. Today, I got chance to present complex coronary intervention in front of the different stages of career. Few are beginner, few are at intermediate stage, and few are masters of these techniques. So when I was looking at this topic, this was complex coronary intervention, the first thing come in my mind that what is simple coronary intervention? I didn't find any answer. So practically there is no term called simple coronary intervention. Every intervention is complex coronary intervention. And with permission of directors, I squeezed my talk on bifurcation because I expect that they will allow me or give me a chance to talk on CTO in next advanced course. So I will start by presentation of 72-year-old man. This is a true life case presented with angina CCS class 3, and during elective angiogram this patient has become a collapse or hemodynamically unstable. In this there are few views. In these views it doesn't look like a true bifurcation, but believe me, it was true bifurcation. So we planned to tackle this patient having two-stent strategy. And in left main, you all know that two-stent strategy, the best two-stent strategy is DK crush. And many of you have already done these cases independently. So we completed this procedure with excellent results. You all can see that there is an intra-aortic balloon pump. So what's bifurcation incidence? Bifurcation lesion accounts approximately 15 to 20% of all percutaneous coronary intervention. And coronary bifurcation stenting is still complex and associated with the high risk of stent thrombosis and restenosis, even era of drug-eluting stent. When being interventions, we look, we do coronary angiogram of any ad hoc patient, we see there is bifurcation. From there, we start thinking that this patient will not do as good as an isolated type A lesion in single artery. So the inherent difficulty of bifurcation PCI stem from the fact that stent implantation is in the main branch may lead to impaired coronary blood flow in the side branch. That's our first concern, and we presume that. However, clinical relevance of side branch is notoriously difficult to standardize. जब हमें कॉल आती है कोई बताता है bifurcation, that doesn't mean that all bifurcations are same, because the side branch are different, and it mostly dependent on operator's subjective judgment considering the individual patient factors. These are list of factors which you have to consider. They are such as side branch diameter and length, angle between side branch and main branch, and the amount of myocardium subtended by the side branch, and myocardial viability, collateralized vessel, ischemic symptoms, and comorbidities, and left ventricular function. These are certain subgroups or certain factors which we have to look. And apart from the acute risk of periprocedural side branch occlusion, bifurcation is associated with the increased risk of long-term stent-related ischemic adverse event, including thrombosis. So that's not only periprocedural side branch occlusion, but there are other things are associated with the side branch with this bifurcation. So what's basic understanding for coronary anatomy for an intervention, that is important. Assessment of 3 diameters of bifurcation, that's proximal, distal, and all vessels are involved. Then assessment of lesion length and plaque distribution, and assessment of bifurcation angle and side branch asked him. These are very important 3 parameters which must be considered when you are planning to deal with bifurcation. Regardless of a stenting technique chosen, the initial step for successful PCI bifurcation strategy is good understanding of bifurcation anatomy. And there are a number of ways you can classify these bifurcation, but we 90 or 99% of all us only use one classification, that is in number 6, that is Medina classification. And I hope that everybody has remembered it on his tips. Then the important thing, sometimes we see that the parent vessel is also has disease. Then it's very difficult to say whether how much we can see predict what is the parent vessel. Like in Dr. Naeem Mengel's discussion, somebody asked that what's normal. But if you see that the healthy size of daughter vessels, then there is a important formula from all these three is a finite formula where you have to add diameter of daughter vessels and multiply it by 0.67 or some people say 0.7, then you can get answer. Then assessment of side branch. There has been a considerable historical debate about how to assess relative importance of side branch. This debate arises from the element of inevitable uncertainty about the likely consequences of side branch occlusion. As I have already said, that all side branch are not same. And data using CT angiography and FFR confirm the side branch supplies less myocardium than the main branch, and that stenosis of side branch is less likely cause to relevant ischemia than the similar stenosis of the main branch. So for sure, if you're going to deal a bifurcation, it's for sure from multiple randomized trial that single stent strategy is better. That is provisional stenting, and we all are always prefer that, except for DK crush, which has the scientific evidence that 2-stent strategy is going to be better, which I am going to show you in next few slides. So what are the step-by-step approach? Regardless of technique, stenting technique chosen, the initial step for successful bifurcation strategy began with good understanding of bifurcation anatomy. That's the same thing which I have already tell you. There are 3 steps. Then almost all bifurcation lesion, including the distal left main coronary artery, can be safely treated via radial artery approach. So it's a myth that when you try to use 2-stent strategy, always go for femoral. We in our cath lab has used 7 French sheath and 7 French guider from radial if it's a good size artery. So you can do all procedure by radial approach as well. Then according to EBC, European Bifurcation Club trial, the consensus of bifurcation PCI, EBC 13 consensus, the left main bifurcation PCI, ESC guidelines, the coronary revascularization, except some special situation when complex 2-stent strategy is indicated. The long-term clinical outcome are determined by the status of main branch after bifurcation stent. Ensuring optimal result of main branch should be given priority over the optimization appearance of side branch if there is a need of choice between two. So main branch, we all know, is more important. This slide will show the single stent strategy or provisional. You can see here 2 wires, then there is a stent, then there is a pod proximal optimization technique, and final kissing balloon. Then this is very important, that when to predilate both branches. It is recommended to predilate main vessel for proper stent sizing, but side branch should not be predilated when a provisional strategy is intended because of fear of ostial side branch dissection. Then you have to commit to put another stent. And selection of main vessel size, we usually discuss this point in our cath lab, that you have to select stent size from the reference of distal diameter of the vessel. And there is a problem that proximal might not oppose there, then that can be overcome by pod technique. And the main branch should be extended. That's very important, that you have to be, main branch should be extended 8 to 10 millimeter proximal to carina for proximal pod. And this sometimes you do provisional stenting, and ultimately you end up by putting 2 stents, that is usually TAP. What is the criteria for that? If the side branch is pinched more than 75% stenosis and TIMI3 is less than 3 and it's an adequate size of vessel, then you must stent that side branch. This is a novel technique, that side branch salvage using the jail wire if failed to recross the main vessel stent. So usually people, sometimes there is a jail balloon technique. Some of you might aware of that you put a side balloon jail by side branch, and when you have this fear of losing the big side branch, so then you can save this, and then by putting vessel in the final, you can see after this balloon inflammation, ultimately you find the path and you can end the procedure. EBC recommendation for using upfront two-stent techniques. A planned two-stent techniques may be indicated for balloon bifurcation with long side branch lesion, difficult side branch access, and high-risk side branch compromise. The vessel anatomy, vessel size, a need for a stenting side branch, first, and operator proficiency affect the choice of a strategy, and recommend techniques include reverse provisional stenting, T stenting, culotte, decay crush, and pot is recommended and ensures optimal stent expansion in both main vessel and side branch, and always finalize double stent procedure by kissing balloon inflation and followed by pot. That's the final step. And this is the important where all interventions attract by this decay crush. This Chen, he's from China, and his colleagues modified the original crush technique as a decay crush technique. This modification made procedure more complex since it required the systemic performance by two kissing balloon techniques. When we do this procedure, I always ask to my second operator to repeat the steps, because there are a lot of steps. If you forget, then you might be in trouble. But has been shown to reduce dramatically the risk of failure performing kissing balloon inflation, and to be clinically effective and safe and long-term in trial conducted by operator dedicated to this technique. When to treat left main? According to European guidelines, myocardial revascularization indicated for the patient with left main angiographic stenosis more than 50 and documentation of myocardial ischemia. However, in clinical practice, evidence of myocardial ischemia may be equivocal, and left main disease is sometimes difficult to assess with coronary angiography. So, non-complex left main disease, when the left main stem plaque involves one branch only, then Medina 110 or 101, the stent strategy should cover the single stent and most relevant to the disease. Usually, it's a single stent strategy or provisional stenting. And the vast majority of true bifurcation anatomies can be approached using stepwise provisional technique, which includes potential to the end and double stenting if needed. An acceptable result on both branches may often be achieved. When this is not a case, second stent can be implanted using different strategy. Then expert consensus suggests T or tape or culotte techniques are adequate techniques for bailout strategy in branch stenting. So this is a double decay crush, and this trial has shown that author randomized 482 patients from 26 centers of 5 countries with true distal left main bifurcation, then Medina 111 or 011, and provisional stenting. They half are randomized to decay crush and half are randomized to this provisional stenting. And rate of target lesion failure, then cardiac death, target vessel myocardial infarction, and clinical driven target lesion revascularization. And what this study concluded, that in the present multi-center randomized trial percutaneous coronary intervention, true distal left main bifurcation lesion using planned decay crush two-stent strategy result in a lower rate of target TLF, target lesion failure at 1 year than provisional stenting. This is the only area where you can have two-stent strategy better than provisional stenting. And decay crush is preferred illustration of no pain, no gain. As I already say, you have to remember the step, you have to repeat the step, because concept doing decay crush in unprotected left main bifurcation lesion will be more challenging than provisional stenting, but will benefit the patient with what is matter the most. It is our strong belief that coronary interventionists will demonstrate an evidence-based growth mindset and adopt DK crush as their standard strategy for treating unprotected left main bifurcation. And these guidelines only this area you might not able to read it, but this says that you can do two-stent strategy where left main is involved. And what's against of it? It commits the operator to adopt a two-stent strategy from the start, and it has too many steps. Each step offers a way to screw up, and technique may cause rewiring outside the stent. That's a big disaster if you wire outside the stent, and ultimately this will be the result if you outside the stent. The planned two-stent approach in left main bifurcation is size of extent of disease. There are multiple techniques. They all are fancy, they are theoretical, but practically, as we have discussed a lot, you might get chance. So this is a small test. Dr. Hakim, you might add some number of this as well, which result you are going to submit in ED office. So this is one of the two-stent strategy, and how beautifully you can see everybody, even a house physician can say, and he can say that I am doing this for sure, but if you go to the lab, definitely you need a lot of expertise, you need a lot of steps. So किसी ने शायद बोल तो दिया, लेकिन even then I will be happy to listen from you what technique it is. Q-lot, excellent. So this is working. This conference is working rather. So there is a consensus of left main PCI technique that provisional is recommended technique for distal left main disease not involving both branches, and elective two-stent strategy may be considered for long circumflex and high-risk circumflex compromise or difficult access, and left main disease involving both branches. Stent techniques should be dependent on the individual patient's anatomical characteristics and operator skills. When a planned two-stent strategy is used, this should be done in provisional stepwise approach to the lesion, finalizing the procedure using T-tap or Q-lot, a crossover from the provisional. For operator with appropriate experience, DK crush is a valuable option for a complex left main bifurcation. And left main, you will listen more from Dr. Navidullah. Probably he is going to talk after my talk. And this is ESC guideline on myocardial revascularization, that stent implantation in main vessel only, followed by provisional balloon angioplasty with or without stenting in the side branch, is recommended for PCI or bifurcation lesion. And in true bifurcation lesion of left main, DK crush technique may be preferred over provisional T-stent. Why it is preferred? You can see here that target lesion failure is less with DK crush than provisional stenting. In the European Bifurcation Club left main coronary study, a randomized comparison of single versus dual stent for true bifurcation left main coronary artery lesion. So the hypothesis is left main coronary bifurcation lesion type Medina classification 111 or 011. Both LAD and circumflex are more than 2.75 millimeter in diameter, best treated with planned provisional single stent strategy rather than planned dual stent strategy with respect to death, lesion, revascularization, and myocardial infarction for 1 year. And the conclusion of this trial is left main has unique anatomical characteristics and demand different technical approaches compared to non-left main bifurcation. And a provisional side branch stenting approach is recommended for left main treatment in most of the cases. And elective two-stent strategy may be considered for long circumflex lesion and high-risk circumflex compromise for difficult cases. And the stent technique should be dependent on the individual patient anatomical characteristics and operator scale. And either T, TAP, Q-lot, DK crush should be used as a two-stent technique. And among two-stent techniques, strong randomized evidence available for DK crush. With this, I thank you all and Happy New Year.